Right, it looks like everyone's in from the waiting room. My name's Angel Soto. I'm the Associate Director of Education for the National Scleroderma Foundation. I'm very excited about today's webinar, where we have the lovely Dr. DeAnna Baker-Frost with us. But before that, I'd like to kind of jump in and do a little kind of housekeeping and make sure everybody's connected properly. So if you are connected properly, you should be able to hear me, you should be able to see the screen, and we are in meeting mode, so you should be able to turn your cameras on and off. All controls that you'll need for today's event can be found on the bottom bar of your Zoom. Starting from left to right, you can reach your mute, unmute button, your camera button, and you'll also see the chat feature there as well. I do encourage you to use the chat feature during the Q&A portion of the session. Feel free to drop in questions throughout the event, and once we get to the Q&A, we'll be sure to jump in there as well. You can also use the raise hand feature if you'd like to ask a question live, and feel free to come off mute, and you can ask that question live to our speaker. But again, thank you for joining us today. I'd also like to mention that today's webinar is being recorded and will be made available on the Foundation's YouTube channel. It should be available by end of day Friday. So definitely check back, and we will be posting it in our e-letter as well. So if you have to jump off early, or if you want to jump back into the webinar, definitely check out our YouTube page on Friday. And again, the National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Now, this information is provided to keep the listeners informed because the manifestations and severity of scleroderma vary among individuals. Personalized medical management is essential. Therefore, it's strongly recommended that all drugs and treatments be discussed with your individual physicians for proper evaluation and treatment. And I'd like to introduce Marilyn Sibley. She's one of our leaders for our BIPOC support group. She has a few messages she'd like to share with the group. The floor is yours, Marilyn.
All right, thank you. Good afternoon, everyone. As Angel said, my name is Marilyn Sibley. I am one of the lead facilitators for the BIPOC, that's Black, Indigenous, and People of Color support group. I would like to take this opportunity to welcome you to our first webinar hosted by the National Scleroderma Foundation. I'd also like to extend a special welcome to our guest speaker, Dr. DeAnna Baker-Frost. Thank you, Dr. Baker-Frost, for agreeing to be our guest speaker today. We appreciate it. So the first question I would like to pose, and some of you probably don't know, is who is BIPOC? BIPOC is a National Scleroderma Foundation virtual support group created to support the needs of African American, Asian, Hispanic, and Native Americans diagnosed with scleroderma. Although the group focuses on the needs of a specific audience, everyone is welcome to join the group. What is our purpose? The purpose is to provide Black, Indigenous, and people of color and their caregivers with safe environment to receive scleroderma education information, a chance to learn about the risk factors of the disease, and how it impacts their lives. To also offer effective resources, provide an opportunity for members to share personal experiences and feelings, as well as coping strategies to address the topics relative to this group. What is the benefit of the group? The benefit is being a member of this group includes the opportunity to network with patients from across the country who have been diagnosed with scleroderma, to participate in innovative programs and topics tailored to the needs of the group, and share similar experiences. Our BIPOC team consists of 6 trained facilitators from different regions of the country. They are as follows: Eva Marie Cole from Tri-State Chapter, Zenobia Harrington from the Pacific Northwest Chapter. She is my co-chair or co-lead. Latrina Hill, she's from the Upper Great Lakes Chapter. Christy Lorenza, she's from the Texcoma Chapter. Aaron Moore, he's from the Pacific Northwest Chapter. Myself, Marilyn Sibley, as one of the leads. Shade Taylor, she's from the she's from the Mid-Atlantic Chapter. And Caprina Bass, who is our mentor. She is from the Caprina Bass Consulting Firm. Before I turn the mic over to our hosts, the BIPOC members would like to thank Angel Soto and the National Scleroderma Foundation for hosting this event. We hope you find today's webinar very informative. Again, thank each and every one of you for participating today. And just to add a little caveat, I hope some of you will attend the one that's going to be that we're hosting tomorrow as well. Turning it back over to you, Angel.
Awesome. Thank you, Marilyn. You are too sweet, too kind. But thank you. And with that, I'd like to introduce today's speaker, Dr. DeAnna Baker-Frost. Dr. Baker-Frost is an adult rheumatologist with a clinical interest in autoimmune diseases and fibrosis. She's a native of Baltimore, Maryland, and she completed her combined doctorates at MUSC and an international medicine residency. I'm sorry, losing my words today, at Duke University. Upon completion of her residency at Duke, she became a board-certified internal medicine physician and returned to MUSC as an adult rheumatology fellow. Dr. Baker-Frost has been awarded several research awards locally and nationally, and has presented her work at several national conferences, including the American College of Rheumatology. She has published a number of scientific articles in prominent journals based on her research. She also volunteers at local patient education events to help people understand autoimmune diseases, explain current treatment options, and answer questions about their health. She's also a grant awardee from the National Scleroderma Foundation, and she's participated in several of our conferences and several of our events. So thank you, Dr. DeAnna Baker-Frost, and welcome.
Thank you so much, Angel, for that very kind introduction. So good afternoon to everyone. I am so happy to be here. Thank you again, Angel, for extending to me the invitation to be a part of this webinar series. As Angel said that I'm an adult rheumatologist at MUSC. I'm in Charleston, South Carolina, and I have a passion for scleroderma. I do scleroderma research, and I also have been an advocate and supporter for our patient support group in the Charleston area. So I am here to have a lively and interactive discussion with everyone. So I hope you brought your questions ready to go so that we can learn more about health disparities. So if anyone has any questions off the back that they would like to answer, feel free to either put it in the chat or you could say it out loud if you desire. But I can kind of start us off by at least talking about what is health disparities. So health disparities is basically when we have a disease process, but we see that there's different outcomes in different populations of patients. And so that is a disparity, meaning that there are differences that occur even though the same disease process and treatment management is occurring in the patient populations. And so when we see these things happening, one of the things we worry about or we get concerned about is why these disparities are taking place. And so the study of health disparities has been a really hot topic that's been occurring over the past several years in medicine. So it started off by really studying if there were biologic differences in the patient populations, if that could explain why you may have different outcomes depending on certain patients and how they may respond to medications. And so that was kind of the first iteration, I will say, of health disparities. Since that time, we have broadened our definition and broadened our research perspectives as to how we should approach health disparities. So we not only look at the biologic differences that may occur between patients that could explain the manifestations of their disease, but we also look at social determinants of health. So social determinants of health are other factors that's outside of biological differences that may impact how a person may respond to treatment or may have different manifestations of their disease. So for instance, you could imagine if someone does not have the opportunity to have health insurance. And so that would impact their treatment course. And so they may have a delayed diagnosis, which means that they could have a longer time in which they're able to seek care and start treatments. So that's one way social determinants of health could impact a disease outcome. Another way is maybe having income disparities. And so those patients that are able to afford their medications because of high cost of co-pays, for instance, could impact how well they're able to respond to treatment. So if they can't take their medications, then clearly there's going to be a delay in which they're able to get their medications and start treatment plans for that. There could be differences, for instance, in rural and urban settings. And so we know that a lot of times we have a lot of our centers are located in certain areas of the country. And so if there are places that are underserved in as far as having access to hospitals and medical centers, and again, that's another way that you could have a delay in treatments and getting patients the necessary interventions that they need. And so all of these fall into that category of social determinants of health. And so now as we kind of unpack some of these things, we now wonder, biologic differences may still be there, but until we kind of really understand and address the social determinants of health aspects of the disease, then we may continue to have these health disparities. So that's where the conversations are now going towards research. There's lots of research focus on social determinants of health and how we can make sure that we address these concerns. We recognize that these concerns exist so that we can better equip and better care for our patients. So that's kind of a broad definition of health disparities, kind of social determinants of health, and how we see how all of these things can interact and can lead to some of the outcomes that we see in several different diseases, but also specifically in scleroderma.
Thank you, Dr. Baker-Frost. And we did have several questions come in prior to the webinar as part of the registration process. So I'll jump in and kind of ask a couple of these questions. But I do also want to encourage everyone, if you want to jump in and ask your questions live, or if you just want to put them in the chat, feel free to do so. So you touched on a bit of some of these questions, but this first question here is, I live in a rural area and I feel like my voice is not heard. There are no specialists in my area and I can't travel. What's the best way for me to find an expert near me?
That is a great question. And as I mentioned before, that definitely can impact someone's not only their access to care, but, not feeling isolated in their disease process, because that's a part of it too. Community is really, really important. And we need to have that community amongst your medical care team as well as amongst patients to help be supportive to get through the illness. So one of the big factors I would say is probably the National Scleroderma Foundation. They have lots of resources on their websites, and what they do is they outline the places that really focus on scleroderma care. And so the person who submitted the question, I'm not exactly sure where you're located, but if you go to their website, they have a map of the entire country, and it outlines where centers specifically focus on scleroderma care. And so if there is a center that's close by, that could be a potential option for you. If there is not a center that's close by, I would urge you to reach out to speak with your primary care doctor if you do have one, or the person that diagnosed you with scleroderma in the first place. We as physicians never have a problem with communicating with other physicians about issues with patients, about treatment management for patients, about anything that we can do to kind of help the management of patients if they can't get to our center. So I can speak specifically for us at MUSC. We're constantly taking calls and taking referrals from physicians for patients that may not be able to come to us in person, but we can at least communicate with them over the telephone, through Zoom meetings such as this so that we can provide at least some information and guidance to help with the treatment plans. We definitely understand the burden that it can that can occur, but living in far away communities. And so we're committed to helping to manage that burden so that it's not passed on to the patients. And I think one of the best ways is kind of utilizing our physicians and physician networks so that we can work together so that you don't feel like you're not able to get the proper care because you're in a certain area of the country. I also would say that the National Scleroderma Foundation also has great access to patient support groups too, because as I mentioned before, community is really important. And I think that going to their website, finding where those support groups are. I know our local support group only meets virtually. That means you don't have to travel to another location. You can just, if you have that access through computers, you can reach out to support group members that way. And then that's another way to kind of stay connected to the community as well.
Thank you. And you that got me thinking a little bit. I know when COVID was out and coming about, there was a huge explosion in virtual appointments and telehealth. How is that? Has that closed the gap a little bit in some of the health disparities? Has that helped, especially with the rural areas?
That is actually a really good question. And so I don't know the data behind it, how well that having better access from telemedicine point of view has kind of closed some of those gaps. I think as the years go on, we'll probably have more data and be able to answer that question better. But I will say that, kind of looking from our one center, we have been able to accommodate patients more often and more frequently that live in other areas of the country easier because of telemedicine. Now, every university and every healthcare center has their own rules kind of surrounding that. Unfortunately, in South Carolina, we're not able to do telemedicine visits for people outside of the state. So you still have to be located in the state of South Carolina to do telemedicine visits. That's something specific to our state, which may not be this case for other areas of the country. However, we do think that, having telemedicine has expanded our reach so that we're at least able to accommodate patients that may not be able to at least travel to the center directly. So that has been one benefit of COVID, if I can say if there are any benefits to COVID. That was one thing that came out of it, that we were able to expand telemedicine more frequently.
Yeah, thank you for that. And that's fantastic points to always check with your local center or with their nearest center to see if that's something that is offered. Another question that came in was I've read that scleroderma is more aggressive in African Americans. Do you know why? Is there any research happening to figure out exactly what's going on?
That is also a very good question. So there have been several studies to show across different centers that when African American patients and other people of color are diagnosed with scleroderma, it does tend to be more severe, and unfortunately, it also has a higher mortality rate when that happens. And so that has been the biggest focus of what we talked about with health disparities, trying to understand why that is the case. And so there's been several studies looking at if there are differences in antibodies, are there differences in proteins that are produced in people of color or African American patients with scleroderma and those that don't. And there have been some studies that have shown some of these differences, but there hasn't been one study that specifically outlines what are the causes of these differences, which kind of leads us back to my beginning points in that there may be some of these biological differences. Like there could be certain proteins that are expressed more frequently in African Americans than others, but it's not the whole story. And that's why we've kind of started looking at other factors that also may impact the severity of the disease process in African Americans and other people of color. So those social determinants of health. And those have also been very eye-opening, helping us understand how to better get access to the specialist how to diagnose the disease faster and start medication sooner. So, and if you have been around me at all, it's never a one-sided, one thing fits all. It's typically multiple different factors that kind of factor in to lead to the outcomes that we see. And so there are some biologic differences, and there's several studies that are focused on looking at those biologic differences, but there are also equally as many studies looking at those social determinants of health to try to really understand it better so that we can close that gap so that we don't see those differences any longer.
Thank you. And we got a question in the chat from Eva Marie. Says, effective April 1st, I read that telemedicine will not be covered. Will there be any exclusions related to hospitals or doctors?
So yes, Eva Marie, thank you for bringing up that point. There is currently, that is what the legislature is saying. So as of March 31st, you will not physicians will not get as much reimbursement if they engage into telemedicine services. It remains to be seen if that exactly will happen. Oftentimes, there have been extensions that have been put into place every time we get closer to these deadlines. So it will really be dependent upon kind of what happens. And when we talk about reimbursement, the reimbursement is based on, I believe, Medicare. And so kind of when those rules are set for Medicare, oftentimes it ripples through other insurance plans as well. Like private insurance companies oftentimes will take the same path as Medicare would take. So as of this point, we don't know if there'll be any exclusions. And as of this point, we don't know if there'll be any further extensions. There's been several extensions that's been put into place prior to this most recent ruling as of April 1st, but it kind of remains to be seen. So I would say it will be really important to kind of keep a close eye on it. And again, as Angel says, reaching out to your local insurance plans as well as your local hospitals and doctor offices to kind of see how they'll handle that if this does continue to play out.
Yeah, that's a really good point. Oh, and Eva says, thank you for the additional info. I honestly don't know how the physicians are able to kind of keep track of all of the constant changes. So,
We
uh,
have very lovely people that
yeah.
helps to keep us abreast. So it is definitely things that are changing on a day-to-day basis. So we're very grateful for them that kind of keeps us abreast of everything that's going on.
So, and here we have another question. My primary care physician doesn't think that I have scleroderma, but I have Raynaud's in my wrists, ankles, hands are always hurting. I also have some acid reflux. Should I be asking for tests like an ANA, or are there other antibodies that I need tested?
That's a very good question. So the ANA test is a great screening test for different autoimmune diseases. The problem with the ANA test is that it's not very specific. And the other problem is that a lot of times patients or people can be positive for an ANA, and it doesn't necessarily mean that they have an autoimmune disease, and it doesn't mean that they'll actually ever develop an autoimmune disease. So about 20% of the population may have a positive ANA test and never go on to develop an autoimmune disease. So that's the kind of pros and the cons of the ANA testing. I would say, if you're still really concerned that you have scleroderma based on some of the symptoms, you could always request, a referral to a rheumatologist. And then that way you'll have someone who is familiar with diagnosing scleroderma to look over, your symptoms. At that time, they could order more specific testing based on kind of what your symptoms are to give you a second opinion based on, how you're feeling. And hopefully that will, get you the diagnosis that is required if that is indeed what you have, scleroderma. And it'll also help, your primary care physician to make the adequate diagnosis. So I always, recommend a second opinion. I don't think that your doctor would, be opposed to that. and it could help you in the end get the diagnosis that you need.
Thank you. Next we have I have ILD and I'm a Black woman. How much more likely is it that I'll get severe lung damage? Are there tests that I should be asking for?
That's another great question. You guys are also asking very good questions. Um, so, because of your race, it is likely that you could develop interstitial lung disease, but we also look at kind of the autoantibody profile. So, as we mentioned before, the ANA test, for instance, is a type of autoantibody that our bodies may produce if you have certain autoimmune diseases. And so some patients with scleroderma will develop certain autoantibodies that will make it more likely that you may have a more severe course. And forgive me if I sound like I'm kind of hedging my bets because nothing is 100%. So that's the other caveat of that I want to address. Even though you may have certain autoantibodies or you may not, it's not 100% that you'll have one disease course or another disease course. As Angel mentioned in the very beginning, everyone's course is very different. And so close follow-up with your physicians is really, really important. However, in addition to the autoantibody testing, which can be helpful to predict disease courses, we also recommend doing regular pulmonary function tests or breathing tests. Those are the tests when you go into the telephone booth. You can see I'm dating myself. You go into the telephone booth and you take these big breaths in, you big breaths out, and that is a way that we can measure kind of your lung capacity, how much air you can take into your lungs, how much air you can breathe out of your lungs. And so looking at that over a period of time kind of gives us a trend. And if we see kind of declines happening on a regular basis every time you do these tests, then that makes us more concerned that you might have a more severe course versus less severe course. So we recommend having these breathing tests done about every 3 to 6 months or so. The other test that we also do is a walk test. So we often have people come in and they walk for 6 minutes. It's called literally a 6-minute walk test. And so from there, we can, again, over time, watch how long you can walk, watch your oxygen saturation as you're walking. And so both of those measures on a regular basis helps us to kind of come up with a prediction of if we think you might have a more or less severe disease course. And in some people, we also follow the CAT scans of the lungs as well. So those, in addition to the antibody testing, those other testings also give us a really good idea of how someone's disease course may be. And it's more individualized as well, outside of looking just at the ethnicity or the race of the person.
That was extremely helpful. Thank you, Dr. Baker Frost. We do have a hand raised from Desiree James. Feel free to unmute and ask live.
Hi, Dr. Baker Frost. Thank you for being here today. When I was diagnosed about 17 years ago, one of the things that my rheumatologist mentioned to me, she said, as an as a Black woman, I need to make sure that I get my blood pressure checked on a regular basis because kidney issues are very prevalent among our community when we've been diagnosed with scleroderma. Have things changed over the last 17 years? Are kidney issues still a big issue among the Black community with regards to scleroderma?
That's a very good question, Ms. James. Thank you so much for asking it. So what Ms. James is alluding to is something that's called scleroderma renal crisis. And when that entity happens, people may develop very high blood pressure levels that could lead to kidney damage. And so in those with So let me kind of back up for a second. There are certain risk factors for people that are more likely to develop scleroderma renal crisis. So for those patients that have the diffuse form of scleroderma compared to the limited form of scleroderma, they're at a higher risk of developing scleroderma renal crisis. For certain patients that have certain autoantibodies, again, autoantibodies, they are also at a higher risk of developing scleroderma renal crisis. And there is a higher risk in those patients that are African American or Black. They are at a higher risk for developing that as well. And so oftentimes what we recommend, or all the time, what we recommend is having regular blood pressure checks. So I tell my patients that you should check your blood pressure at least once a day. Now you can get just a regular blood pressure cuff from your drugstore. It doesn't have to be an expensive or fancy one, but at least check it once a day, not after you've gone outside and mowed the grass and then come inside and check your blood pressure. Of course, it's going to be high at that point, but at a point in which you're at the most relaxed state, then you check your blood pressure. And if it's consistently high, meaning that the top number is greater than or equal to 140 on a consistent basis, like 3 days in a row, the bottom number is greater than 85 on a consistent basis, then you need to talk to your rheumatologist or your doctor as soon as possible, because time is money when it comes to this entity. We would need to start you on medications as soon as possible. And there's a specific medication that you would have to be started on. So not all blood pressure medications treats scleroderma renal crisis. And the quicker we can start you on that particular medication, the faster we can kind of save your kidney function. So for anyone who has scleroderma, especially a new diagnosis of scleroderma, has diffuse scleroderma, is African American, we would recommend kind of checking your blood pressure at least on a daily basis. Oftentimes, my patient keeps it in a little spiral notebook and brings it to their appointment so that we can go over it together, so that we can see if there are any kind of long-term changes. But if you yourself notice that these numbers are more elevated than they should be, then by all means, reach out to your physician as soon as possible.
Thank you for that fantastic. Oh, yep, Jesse. Thank you. That's huge. And we have a follow-up question to that in the chat from Pat De Jesus. They ask, is there any symptoms to watch out for renal crisis aside from blood pressure?
That's also a very good question. So blood pressure is our first kind of key that something's going on. Some patients may have kind of headaches. So with high blood pressure, oftentimes people may have headaches associated with that too. Sometimes you may have decreased urination. So part of the things that our kidneys do, they're like the big filter in our body. So they filter out all of the toxins and things, and we get rid of it in our urine. And if you start having problems with your kidneys, you don't urinate as much. So if you start noticing that you're having kind of decreased urination, that could be another sign that your kidneys may not be functioning as they should. So any one of those things would be reasons to reach out to a health professional as soon as possible.
Thank you. And another question we have is, I've seen scleroderma talks before that say treatment can be different for African Americans and other groups. Some treatments may work better for us, but aren't always the first choice. A follow-up, do insurance companies know about this? I feel like it may be able to help us a lot.
So that's also a very good question. So at this point, we don't have 100% definitive evidence that certain medications work better for certain groups. So there was a study that was done several years ago, kind of looking at different groups of patients of different ethnicities that have scleroderma and kind of comparing cyclophosphamide treatment to CellCept treatment. And there was some indication that one of those treatments may be better in patients that are African American compared to those that are not. When you have a study like that, it is important to kind of repeat those studies in multiple different groups. So this study was at one center in the United States. And so it's important to kind of mimic that in other groups to see, to make sure that it's something that's widespread, that you can make a big conclusion that, yes, this is indeed the case, that one group does better with a certain medication than other groups. So at this point, we're not necessarily ready to say that, yes, African-American patients should be on this medicine over another medicine if they have scleroderma. But I think it is an interesting question. We have seen that in other diseases like lupus. It has been shown that some groups of different ethnicities do better on a certain medication than others, but we've yet to make that kind of final definitive conclusion for scleroderma.
Oh, that's very interesting. Hopefully we get to a point where we're able to kind of figure that out, right?
That'd be interesting.
Yeah, and let's see, we have, are there any programs at hospitals and clinics that help cover the cost of travel or the cost of medications? I'm on Medicaid and can't work.
That's a very, very, very good question. I will have to say that off of the top of my head, I don't know of any widespread programs like country or nationwide programs that kind of cover those costs. I will say a couple things, however. For medications specifically, there are a lot of patient assistance programs for that. So if you talk to your provider, they can talk to insurance companies and typically pharmaceutical companies, actually. And they oftentimes will have different medication programs in place for patients that meet a certain income level, and they're able to get medications either at low cost or at no cost. And so oftentimes that's something that we screen for at our university, at least, just to make sure that everyone has access to their medications. As far as kind of travel to and from clinic, I don't know of a nationwide program that has that. However, I encourage talking to your provider to reach out if there's something local, like if that is a local a subset of funds that they have that would be of assistance for kind of travel. But for medications, especially the newer medications, there are oftentimes some type of assistance to help patients be able to afford that.
Great. I think that's something that us as the National Scleroderma Foundation, we can definitely start putting more of that information out there for our folks. Yeah, and we've got a follow-up question in the chat that says,
Can I add something to that?
Oh, of course.
I
Please.
know in the state of South Carolina, if you have Medicaid, if you check with your local Medicaid office, they do have a transportation program. So you might want to check with whoever you sign up with Medicaid for, their local office. Some of the offices, they do provide transportation. So you might want to check with your local Medicaid office.
Thank you for that, Ms. Fields. That's very important.
Yeah, thank you. And a attendee asks, what should we do if your pressure is extremely low?
Yes, so that is just as dangerous actually as having high blood pressure. You're not necessarily at risk for what's called scleroderma renal crisis. That's for people with high blood pressure. However, when you have low blood pressure, that's equally as concerning because you have to think, your blood pressure is there so that it can, you can pump blood to all of your organs, your brain, your heart, everybody needs blood. So if you have extremely low blood pressure, oftentimes you'll have lightheadedness, you may have dizziness, you may have extreme fatigue. All of those are very dangerous signs. You're at risk for passing out and for falling and all of those things. So one of the biggest reasons I see for low blood pressure is often medications. So I would urge you to kind of discuss with your physician about the number of medications that you're taking that may have a potential effect on your blood pressure. So sometimes the medications that we use to help with the Raynaud's phenomenon, for instance, we don't think of it as a blood pressure medicine, but oftentimes they can also lower your blood pressure. So having a combination of those different medications together can work together to cause lower blood pressure. So if you do have episodes of low blood pressure, I would highly suggest talking to your physician about it to see if there's certain things that can be done, certain medications that can be stopped, to start at least investigating the cause of the low blood pressure.
Thank you. And what would be considered low blood pressure? No.
Yeah, that's a great question also. So the ideal blood pressure, I think we probably have all heard at some point, is 120 top number over 80 bottom number. So when you start getting the top number being kind of on the 100s, sometimes if it gets to the 90s, those are where we start getting concerned about low blood pressure. Now, again, when we talk about blood pressure, it's also an average. Every person is different. So not everyone's going to have that magic 120 over 80. But that's why it's also important to kind of monitor your blood pressure, because then you get to know what your typical blood pressure is. And so there could be someone out there whose typical blood pressure is 109, and that's just kind of where their blood pressure is. And so, but typically, broadly, when you start having a top number in the 90s, that's when we really start getting concerned about it may being too low, especially if you're starting to have symptoms of lightheadedness, dizziness, problems with fatigue, not being able to think clearly. All of those could be signs that your blood pressure is too low.
Thank you. And we have another question. What are some positive steps we can all do, if anything, to assist in stopping health disparities?
Oh, wow.
Yeah, it's a big one. It's a big one.
That is a huge question. That's a huge question. I think the biggest issue is recognizing that they exist, and so I think, for a long time there was not a recognition that health disparities was real. A lot of times, the thought was, oh, someone's just not, quote unquote, doing what they're supposed to do, and that's why their outcomes aren't as what they are. I think now we're starting to recognize that you can do everything that you're supposed to do as far as taking your medications and those types of things, and outcomes are still different. So recognizing that health disparities exist is the first step. I think the second step is talking to, I'm not getting political, but I think reaching out and talking to, like politicians and things about how important it is to make sure that we have adequate health care, making sure that, prescription drugs are not too expensive, making sure that, everyone has coverage with like Medicaid and Medicare. Like all of those things are really important to make sure that everyone has equal access to getting to doctor's offices and taking their medications. And that alone can help to improve access, to care. So I think that that's also really, really important, reaching out and just kind of, expressing what your story is and what your concerns are about how people are adversely affected when they don't have access and when they don't have the necessary resources that they need so that they can have better outcomes. So I think that that's the second thing. I think all of us can kind of do those things. And I think lastly, the other big issue is that if you yourself are experiencing these issues, don't be afraid to reach out and don't be afraid to talk about it with your provider. So I often say that if I don't know what's happening, then I can't help to fix it. So if there is an issue that's going on, and if you are having issues with getting medications, or you are having issues getting to your appointments to see me, let me know and see what we can work out, see what what resources are available to us so that we can kind of work together on this problem, so you don't feel like you're isolated and you're in it by yourself.
I think those are all fantastic points. And you touched on it. Sometimes it can be scary to talk to your doctor and tell them how you're feeling a little bit, because they are the expert. But like Dr. Baker Frost mentioned, they want to hear what's going on. They want to know. It's the best way to build that strong relationship. So thank you. And another question we have is, do clinical trials do anything specific to recruit more people of color?
That is a great question. So, again, another big breakthrough that's happened over the years is that we understand that because not everyone responds to medications equally, that it's really important to have a representative population within clinical trials. So if we don't have the adequate numbers of diverse people in clinical trials, whatever outcomes we get from that medication, we may not know if it adequately will treat people of different backgrounds. We kind of already mentioned that there may be some drugs that work better for certain populations than others. And if that is the case, then that means we need to have diverse people in our clinical trials so that we can parse out those differences if they do exist. So drug companies do recognize that now. I personally have had representatives from different pharmaceutical companies come to me to ask me about how to recruit more people of diverse backgrounds. So it's definitely something that is on their radar. It's something that they are looking, I can't say all, but there are some that are looking to increase and diversify their patient population. So they do recognize that it is important, and they are trying to do that. I think the key now is trying to understand how to reach these different populations and how to reach people and how to get the word out about clinical trials and increasing participation among different groups. So yes, it is on their radar, and they are trying to do so.
That's great to hear. And a follow-up to that is, if for those folks who don't live near a center that's conducting trials, are there ways to participate virtually, or do these clinical trials assist with travel?
That's a great question as well. So oftentimes there are trials that do assist with travel. So there are some instances where that can be done. Virtually is a little bit more difficult, oftentimes because this is an experimental drug that they're trying to test to make sure it's safe and, test for improvement in scleroderma. You have to be seen in person for that. And so they have to, when I'm a physician on a clinical trial, I'm, listening to hearts and lungs and, measuring skin tightness and all of those things that can't be done virtually. So oftentimes you do need to be able to get to the center so that those tests can be done. However, there are some trials that do provide financial compensation so that you are able to make it to the centers if necessary. And that's really just on a trial by trial basis. It's just kind of how the companies have designed and set up the trials. But I think that's a great idea, and I hope more companies will make their trials so that if travel is a financial barrier, then that's something that can be compensated for.
Awesome. That makes a lot of sense. And I want to encourage everyone, we're close to the top of the hour. If you do have any final questions for our guest speaker, please feel free to drop them in the chat or raise your hand. And kind of our last question that we received prior to the session is, what would happen, and this is a big one, but it's what would happen if I lose my Medicaid? I can't afford to see my doctor without that insurance.
Boy. That is a very tough situation. And I will say that I do have some patients, unfortunately, that did lose their health insurance. But don't feel like you're alone if that were to happen. Again, there just stay in close communication with your provider. I know personally, there are, again, assistance programs that can be used for people that don't have health insurance to make sure that they are maintained, on their medications. As it comes to clinic visits, it may be a little bit more challenging, but there are definitely ways, financially that can be worked out, through certain funds that the hospital may or may not have. So again, I think the biggest concern that I have is that when I have patients that lose their insurance, they leave me and I don't know what happened to them and they're out there in the world. So stay in close contact. And if that were to happen, reach out to your provider to let them know what's going on again, so they can kind of start looking and searching for ways to kind of at least keep you on your medications while they're kind of figuring out and working out what to do to help from a financial standpoint. The other thing is most hospitals have social workers as well. And so our social workers are there to help navigate some of these issues also. So they're there to help figure out about alternative forms of insurance and other things, so that people aren't left out there. Our vested interest is in making patients better. And so we're committed to that. And so we're always available and willing to help find resources so that you can continue to get better even through difficult financial times.
Thank you. And it's a heavy topic, but I appreciate that. And we have one more question here from Latrina Hill. Having ILD, I have been taking Linespro for my high blood pressure. It's known to have coughing as a side effect, and I know we are all different. Any thoughts on that particular drug?
So yes, Ms. Hill. So lisinopril is one of those medications that it's a very common side effect is to have a cough. So a couple things with that. So that can make it tricky when you're trying to figure out if your ILD is worsening and that's what's causing the cough versus if it's the medication. So again, having those breathing tests done and those walk tests kind of helps to tease out if the cough is related to the lisinopril versus if it's related to the ILD. That's the first thing. The second thing is lisinopril is one of those medications that's used to treat the scleroderma renal crisis that I talked about before. So if you do have a history of scleroderma renal crisis, and that's why you're on the lisinopril, I'll be a little bit cautious about stopping the medication prior to talking to your physician about it, because there may be a reason that you have to be on that particular medication and not another one. So just again, talk with your provider about the issues that you may be having with it, and they can kind of help you sort out what's going on with it and if therapy changes are necessary.
Thank you. And we have a few comments coming in just thanking you for the fantastic talk and also sending thanks to Marilyn as well. It looks like we don't have any more questions. So with that, I want to give you a huge shout out, a huge thank you. Thank you, Dr. DeAnna Baker-Frost, for joining us today and answering all of our questions. I also want to thank Marilyn Sibley for joining us and all of the facilitators for the BIPOC support group who are on the meeting today and all of our attendees. I also want to give a shout out to the BIPOC support group and let everyone know that the support group does meet monthly. If you do have any questions about those meeting dates, you can email any of the facilitators. I'll add Marilyn Sibley's email address to the chat, so you can email her directly for any questions about dates and times of the meetings. And I also posted a link in the chat for tomorrow's webinar if you're interested in attending. With that, Dr. DeAnna Frost, yes, go ahead, Marilyn.
Can I jump in just for a minute?
Absolutely.
In the chat, Kate just posted the information around in regards to trials. I don't have the exact topic, but it's there. So any of you that are interested in participating in that, please join them tomorrow evening. This is something that would be beneficial, I think, to all of us to share with that host, the need for participating in trials. So consider joining that. I know tomorrow's probably going to be a long day, but believe me, these webinars are worthwhile, participating and submitting your input. That's how we can move forward and help the BIPOC community as well as others by participating and making sure that our voices are being heard. So thank you. And the BIPOC meeting, next BIPOC meeting is Sunday, March 9th. And yes, we'll be happy to send you an invite. Thank you.
Yeah, thank you, Marilyn. Any parting words for the audience, Dr. Baker Frost?
I think that you guys all had amazing questions. So thank you so much for your participation. I hope everyone learned a lot from this. I enjoyed talking to you guys. I always do. If you have further questions that weren't able to be answered during this topic, feel free to reach out. I'm happy to answer any further questions.
So thank you so much. And the recording for this presentation will be available Friday evening. So keep an eye out on our YouTube page and our e-letter. Thank you, everyone, and I hope you have a wonderful day. Take care.
Bye, everyone.
Thank you, everyone.